So this webinar will be recorded, and the recording has started if that message was not heard. All right, well, welcome. My name is Laura Chicoine, and I'm the project manager for research and education at the Adult Down Syndrome Center. And we are a clinic for adolescents and adults with Down syndrome. We start seeing patients at age 12. We are located in Park Ridge, which is a suburb of Chicago in Illinois. The clinic was opened in 1992, and throughout its 30-year history, over 6,000 individuals with Down syndrome have been seen at our center. Physical and mental health care is provided at our clinic, as well as in the hospital on whose campus we are on, and at residential facilities and nursing homes in the area. Occupational therapy is also a service we provide, as well as parent and patient support and health education and social skills groups and presentations such as this one. Another service we have is our online resource library, and that is a free website that has articles, videos, webinar recordings, and links to helpful resources. And it's for individuals with Down syndrome, families and caregivers, and healthcare professionals. And many are written by the team here at the center, but we also provide links to other organizations who work with individuals with Down syndrome. And throughout the presentation, we will be referring to links on our site. And so we encourage you to take a look at that. As I mentioned, the webinar is being recorded, and it will be available within 2 weeks in our resource library. And I will email that out to all who have registered for this webinar. This webinar is provided for educational purposes only, and we recommend that you bring any information that you learn here to your own healthcare provider. And here's just a bit about the format. Thank you all for submitting your questions. We received so many wonderful questions from individuals who registered for our webinar. If you'd like to submit additional questions, you can use the Q&A button at the bottom of your screen or in your Zoom toolbar. Given the number of questions we received, we may not get to all of them, but again, we share information on our resource library, and we'll continue to share it there. Given the number of questions that we received, we tried to generalize and group them, and that way we will try to address as many questions as possible. Each question has been assigned to a category, and one of our presenters will cover each category. And I have the privilege to introduce our three wonderful presenters. Brian Chicoine, Dr. Brian Chicoine co-founded the Adult Down Syndrome Center in 1992, and he is our medical director. Katie Frank, Dr. Katie Frank is an occupational therapist, and she joined the team here at the center in 2016, but has extensive experience working with individuals with Down syndrome. And we are pleased to welcome our newest physician, Hannah Graham. Dr. Graham joined our team in 2021, but she has quickly jumped in and is a wealth of knowledge, and we're very pleased to have her. So without further ado, I'm going to pass it over to Dr. Graham, who's going to speak to us about our first topic, which is Alzheimer's disease.
Great. Well, thank you so much for that introduction, Laura, and hello, everyone. Hope you all are having a good day. I guess we're going to dive right in, trying to summarize some of the questions that we got with regards to Alzheimer's disease. So we wanted to start by talking about some of the signs and symptoms of dementia and kind of when we might start to suspect that diagnosis. Now, there's not only one tool that we can use to make a diagnosis of dementia or Alzheimer's. In people without Down syndrome, neuropsych testing is the classic way to make a diagnosis of dementia. But those same tests that are used in neuropsych testing are not validated and don't work super well for people with Down syndrome. So there are a few specialized tests that we can use to diagnose dementia in people with Down syndrome, but those tests really work best if they're used over time and if they're done consistently over time. Some of the names of those tests are the Down syndrome mental status exam and the dementia scale for Down syndrome. I think that clinically, when we are making a diagnosis of dementia for somebody, we're really looking at a pattern of decline. We're not looking at just one sign or symptom that really is going to describe or be a hallmark symptom for dementia. It's really that pattern that we're looking for. So some of the things that I start to see popping up that make me start to think about a dementia diagnosis is people who are struggling to gain new skills, who are losing skills that they used to be able to do, who are becoming forgetful, having problems remembering to do things, forgetting routines, forgetting the names of people who are around them on a regular basis. Some of the other things that can contribute to that pattern would be sometimes we see some physical symptoms like incontinence or loss of urine, unsteady gait, problems with swallowing, weight loss. We commonly start to see weight loss when we start to see kind of a dementia pattern appearing, and also some psychological changes. Sometimes it's a new diagnosis of depression or anxiety or other psychological symptoms that start to crop up. Sometimes we can see seizures. And so a lot of things can play in. And I think the really important thing to think about is that we're really looking for a pattern and not just one symptom to kind of be thinking about for dementia. Now, an important question is, what age do we start thinking about Alzheimer's for people with Down syndrome? You know, most of the time, Alzheimer's is diagnosed in the 50s or 60s. Sometimes we see it in the late 40s. When I start to see people who are having some of these symptoms that I'd mentioned before in their 30s or 20s, I really start thinking about some of the other diagnoses that we might see commonly too, because it's pretty unusual to see Alzheimer's in people with Down syndrome before their late 40s. So that's kind of the age that I start to think about. One thing I always kind of like people to just be aware of is once a patient with Down syndrome really has a firm diagnosis of Alzheimer's, we're sure that's what it is, we have a strong pattern of decline. I think it's important to note that those people are at higher risk of developing a seizure disorder as well after that diagnosis of Alzheimer's. That's important because in people without Down syndrome who have Alzheimer's, we don't see that same significant increased risk for seizures. So I just like families and caregivers and people who are taking care of a person with Down syndrome and Alzheimer's to know that there is an increased risk for the development of a seizure disorder. And so if that ever happens, you know, we get help and we work to treat it. I had mentioned earlier that if we start to see some of these patterns of memory problems happening before the late 40s, if it's happening in somebody's 30s or in their early 40s, we also think about other things first, maybe not thinking that Alzheimer's is the most likely diagnosis. Some causes of memory loss and changes in patterns of dementia for our patients. Sometimes we see depression, anxiety, or other psychological conditions can bring on changes in memory. I think sleep apnea is a huge one. So when people who are in their 20s or 30s are having a lot of memory problems, that's a good thing to think about is when was the last sleep study and do we need to go ahead and get an updated sleep study and test for sleep apnea. It's important when we see you know, that pattern of dementia or any of these above symptoms, really at any age, to do some blood work. Some common things we would check for would be thyroid, vitamin deficiencies like vitamin B12 and folate. Those deficiencies of those two vitamins can cause memory problems. We think about, you know, electrolytes, or is the calcium level normal? So we just kind of do like a metabolic panel. Celiac disease is another thing to think about. We know celiac disease is more common in people with Down syndrome, and sometimes we see it present in kind of interesting ways in our patients, and sometimes it's memory loss. So that's another thing that we can think about if you start to see that pattern of memory problems. Other things we think about is atlantoaxial instability in the neck. Are there any heart disorders going on? Is there a new underlying seizure disorder, other neurological things? Could it be cataracts? Are we having trouble with our vision? Are we having trouble with our hearing? Making sure that our vision and hearing screenings are up to date. All of that can play in. And finally, always want to think about side effects from medications as potential causes of memory problems. I think we're ready for the next slide, please, Laura. Thank you. So individuals with Down syndrome at high risk of developing Alzheimer's disease, and does family history play a role? So, you know, we think that the lifetime risk of a person with Down syndrome developing Alzheimer's at some point is greater than 90%. And that's not taking into account family history. We think that Alzheimer's is caused by the accumulation of beta amyloid plaque in the brain. It's interesting because the gene that encodes for this beta amyloid is carried on chromosome 21. So the idea then is that with 3 copies of chromosome 21, people with Down syndrome make more of that beta amyloid, which is why there are more beta amyloid plaques, and they develop Alzheimer's at a younger age than we would see in the non-Down syndrome population. It's kind of interesting because if you look at some of the familial Alzheimer's diseases, the diseases that can run in families, especially like an early diagnosis of Alzheimer's that runs in families in people without Down syndrome, it kind of, sometimes it replicates the same ages that we see Alzheimer's in people with Down syndrome, right? We see those families sometimes develop Alzheimer's in their 50s or 60s. And we've even seen that some of those like family Alzheimer syndromes, they actually have a mutation on that gene on chromosome 21. So there's definitely some connections there. But I think in general, when we think about people with Down syndrome and their risk for Alzheimer's disease, it is very high. And we typically don't think so much about the family history, only because that greater than 90% is so high to start with. Next slide, please. Thank you. So knowing that there is such a high chance of developing Alzheimer's, this question, and I love when people ask me this question, is, are there ways to prevent Alzheimer's disease? The unfortunate answer is no, but I like to add to that a ... not yet. This is certainly an area where we're doing a lot of research and that people are really invested and interested in looking at the answer to this question. I don't have a proven way to prevent or delay the onset of Alzheimer's disease. Now, there have been some studies that have been done in non-Down syndrome populations. Those studies suggested that exercise and healthy eating might lower the risk of dementia. So while those things haven't been truly proven to work, it makes sense that they might work. And they're so good for us for so many reasons. So I like to encourage people, let's do the best we can. Let's exercise. Let's try and exercise 30 minutes, 5 days a week. It's a good place to start. If you live in a wintry place like Chicago, that can be hard to do during the winter time. But sometimes I say maybe find a dance video that you like to do and do that dance video, you know, every day, so that we're getting up and we're moving and we're getting exercise, regardless of what the weather is doing. And of course, healthy eating is always going to be a good thing for us. So the answer to this question is no, not yet. But we'll do our best by doing healthy lifestyle stuff like exercising and eating healthy. Next slide. All right, so a question about what the studies are showing about amyloid plaque and pTau treatments. So the pTau treatments, pTau is another one of those proteins that we see in brains of people who have Alzheimer's disease. There's a lot of studies going on around pTau right now. Mostly it's being looked at as a biomarker for Alzheimer's. I did see some studies where it was being tested in mice as a treatment option for but that was like a mouse model. So I don't think we're at the point where we're seeing any studies using pTau treatments for people with Down syndrome that I'm aware of. When it comes to treatments for amyloid plaque, there was a drug that was approved by the FDA for treating that. That's the aducanumab drug, which some of you might have heard about. It's a monoclonal antibody. So it's an antibody that's targeting that plaque in the brain. So it was approved to treat Alzheimer's disease. It was approved by the FDA. One study showed that it did seem to slow memory loss, but another study showed that it did not. So this drug has been a little bit controversial. It did not get approved for treatment of dementia in Europe. So just a lot going on with that medication. I think that's what's really important for people with Down syndrome is that people with Down syndrome were not included in the clinical studies looking at aducanumab and whether or not it works. So we don't have any information on how this drug works in people with Down syndrome. And we don't know if we can really safely extrapolate that data that we had regarding people without Down syndrome and say it applies equally to people with Down syndrome. One of the significant, or at least not insignificant, side effects of aducanumab is it can cause cerebral hemorrhage. People with Down syndrome are probably already at higher risk for a cerebral hemorrhage like that because of the way that their connective tissue in the brain is just a little bit different. And so definitely multiple organizations have come out with some concerns about using aducanumab in people with Down syndrome. So right now, there are not any treatments that we are using for our patients with amyloid plaque or pTau treatments to treat Alzheimer's. Next slide, please. Okay, so can prevagen cause or help memory loss? Sorry, can prevagen help memory loss? So prevagen is a supplement that people can buy over the counter. And it's made from jellyfish. It's a jellyfish supplement. Like all supplements, it is not regulated by the FDA, which means that there can be variation from one pill to another pill in the same bottle. So it's not regulated, and the amounts and the concentration and things like that are just a little bit of a guessing game. There are also no good, large clinical trials that prove that it's effective. So in the absence of good data showing that it's effective, I typically do not recommend this supplement. Now, for people with Down syndrome who want to try it, or their families or their caregivers, I think a case-by-case approach can definitely be appropriate. So I always just recommend talking with your provider, because a prevagen or any supplement really, doctors, I like to know what supplements my patients are taking, because they could interact with a prescribed medication, or they could cause a side effect, or could be related to other things. So I always like to recommend, even if people are taking a supplement like prevagen, just making sure that you talk with your primary care doctor about it so that they know and can make sure that there's no other interactions or problems. So next slide. Okay, so these are some of the resources that we have on the website and some links to some other resources. So I think I'm going to hand it back to you, Laura.
Thank you so much, Dr. Graham. One of the questions in the chat was if you could repeat the names of the mental status exams that you referenced.
Oh yeah, oops, I'm sorry. My computer is talking to me or blanking out. So they are the Dementia Scale for Down Syndrome and the Down Syndrome Mental Status Examination.
Thank you so much.
Thank you.
All right, and our next topic is COVID-19 and immunology, and I'm going to pass it over to Dr. Chicoine.
Thank you, Laura. Certainly a timely topic. Lots going on in the world still with COVID. So one of the questions we get asked frequently is, are individuals with Down syndrome considered immunocompromised? Because that frequently comes up with regards to the issue of COVID. So basically what we know from studies is that some individuals with Down syndrome are immunocompromised. That means their immune system does not work as well as it does in somebody else, or does it in somebody in the non-Down syndrome population. And this may include low white blood cell counts. It may include some impaired antibody immunity or B cell function, which is part of the antibody function or system. And it also may include impaired cellular or T cell function. So a lot of different parts of the immune system may be affected by having Down syndrome. However, despite that, people with Down syndrome are not considered one of the high risk immunocompromised categories for the purpose of considering getting a fourth shot at this point, or for those who have gotten the 2 shots and it's less than 5 or 6 months since they've gotten the second shot or the 1 shot of Johnson & Johnson. For some individuals that are considered highly immunocompromised, there was recommendation to get a 3rd shot sooner than the 5 or 6 months. So people with Down syndrome were not included in that based on their immune status. And I'll become a little more clear with this one here. So what is our experience with recommendations for COVID vaccines for people with Down syndrome? So my sense is that in 2020, our practice was severely affected by COVID-19 infection. Our experience was like that of the T21 Research Society study, which we were part of. And we saw a higher rate of infection for COVID and poor outcomes, unfortunately, in people with Down syndrome, especially for those over 40. And for those younger than 40 who have co-occurring conditions, such as congenital heart disease, obesity, diabetes, and others. So certainly we see that our individuals with Down syndrome were more affected by COVID prior to the vaccines being available. Also similar to the T21 study, in our practice, the vaccine has seemed to have been highly effective. We have a very low rate of side effects, really only 1 serious side effect that I'm aware of in our practice. And that was really nothing compared to the serious illness, hospitalization, and even death we saw in 2020. And that's similar to the T21 research study with regards to the vaccine's effectiveness and clinical effectiveness, as well as low rates of side effects. And this seems, so what we're seeing with regards to the effectiveness of the vaccine is comparable to what we're seeing in the non-Down syndrome or general population. In our practice, some of the, since the vaccine's been available, in our practice, some of those in the higher risk groups, over 40, diabetes, et cetera, have been hospitalized. But about 85% of our patients that have been hospitalized in the recent months since the vaccines were available are those that are not vaccinated. So similar to the general population, most of our patients who are ending up in the hospital now with COVID have not been vaccinated, and those that are not typically ending up in the hospital. We are certainly seeing people get COVID, vaccinated or unvaccinated, but those that are ending up in the hospital are most commonly those that are unvaccinated. And again, although the vaccine seems to be working very well, because we do know that some people, particularly our older folks and those with other risk factors, less than 40. And I should mention that in the T21 study, a 40-year-old with Down syndrome was essentially comparable to the risk of COVID to an 80-year-old without Down syndrome. So the age certainly is at a younger age in people with Down syndrome than without that had complications from COVID. But so at this point, again, because of some of our older folks and some of our folks with younger that have co-occurring conditions, when one of our patients gets COVID, we are talking to them about the possibility of taking the Paxlovid, which is the one of the oral medications that is being used to treat people with COVID infection to reduce their chance of getting severely ill or ending up being hospitalized. Unfortunately, it's not always available. So when that is available, we do offer that to our patients as something to consider taking. Okay, next. So there's some of the resources that you can find with regards to the some of the issues with during COVID, about COVID and Down syndrome.
Thank you. And I may have neglected to mention that these slides will also be emailed to you when the recording is available. And our next topic is occupational therapy, and Dr. Frank will be discussing these questions.
Thank you, Laura. So one of our first questions is, what is occupational therapy? And I'm sure since many of you are parents of adolescents or adults, you know that your child most likely received occupational therapy through early intervention or school age. But just as a refresher, OT is a health profession concerned with how people function and perform meaningful activities, in their respective roles. And we all have different roles, even throughout the day, let alone just in life. So occupation is any activity in which one engages throughout the day. And oftentimes I tell, patients and their families, it's, I can help you with anything you do from the moment you wake up to the moment you go to sleep. And even while you're sleeping is something that, I can help address. And OTs help a person perform expected, needed, or even desired activities. And one way we can do that is by teaching or reteaching a skill. So we can maybe teach someone how to brush their teeth with the steps that are required. First you put the toothpaste on the toothbrush, or open the toothpaste and you put the toothpaste on the toothbrush, and we do each of those steps. We can also provide accommodations. So maybe it's providing an electric toothbrush to help with thoroughness of brushing teeth, or perhaps it's a different type of toothpaste so that they can squeeze it and be more independent with putting the toothpaste on their toothbrush. And we can also modify the environment. So maybe they need a stool in order to reach the sink so that they can turn the water on and off by themselves, or spit out their toothpaste. And really, OTs can work with people throughout the lifespan, and we address a number of things. Most people think it's just self-care skills and fine motor skills, and that is many of the things we do, but really any life skill an OT can address, because again, that's our occupation. We might address physical activity. I do a lot with puberty and dating and relationships and social skills. We do address self-care skills and sensory processing. And even one of the main things I do here is to help with transitions and routines, because we know oftentimes in Down syndrome, that can be a challenge. Next question. So when should an adolescent or adult with Down syndrome seek treatment with an OT? And I think it really can depend. And I don't think that therapy is lifelong. I personally think that families should look at considering any kind of therapy, whether it's OT, PT, or speech. When something needs to be learned, a skill needs to be developed, something has happened, and then you can stop therapy. And I think that's great for the person with Down syndrome and for the therapist. And I don't want parents to feel guilty if they choose to take a break from therapy. But some things that an OT might address is, if the person with Down syndrome starts having self-stimulatory behaviors like hand flapping or rocking, but it's not just the self-stim behaviors, but it's really impacting their ability to do anything else during the day. Maybe they have strong preferences for or sensitivities to light or texture, taste, smell, sound, or movement. So really helping address this, the sensory needs of someone. Maybe they're a picky eater, and so an OT can really help with the picky eating, where oftentimes the speech therapist might work more with the swallowing, but some OTs can also help with swallowing, just like some speech pathologists can help with picky eating. If they have the poor fine motor coordination skills, handwriting's a challenge, or typing, manipulating fasteners like buttons or zippers, and that's a skill you want to work on, then an OT can help with that. Maybe they are having trouble with some of their basic ADL skills, their activities of daily living. So maybe the bathing or dressing, brushing their teeth, anything like that, an OT can help with. And we can, even provide visual supports to help learn the steps if that's really the challenge. Maybe, the person with Down syndrome is overweight. OTs are able to work on physical activity and work on healthy eating strategies. And, we actually provide a social skills group on just those things. Maybe they need to learn job skills. We're not actually job coaches, so we're not going to be able to go into that environment, but maybe there are certain skills they need in order to be successful at employment. And so an OT can work on that. There's questions about healthy sexuality or relationships and puberty. Not all OTs are comfortable addressing that, but many can or can refer you to someone who would be appropriate. Practicing appropriate social skills. We run a variety of social skills groups here, and honestly, we see social skills as a really important occupation in someone with Down syndrome. Many times they have great social skills, but sometimes this is where we see they get trouble at work because they see things so black and white, because abstract concepts are challenging. And so we really need to teach them and have them learn appropriate social skills. Individuals with Down syndrome often have trouble with transitions, especially if they're stuck in their routine and they don't want that changed routine. So an OT can help with different strategies to assist with that. Maybe even just establishing a routine, especially during COVID. We've seen that individuals with Down syndrome kind of gotten stuck because there's lack of routine. So helping establish that. And then maybe your loved one has anxiety towards medical procedures or dental visits, haircuts, blood draws, or any other kind of activity that may need to occur periodically. And so an OT can maybe help with calming strategies or sensory strategies to get through those procedures. Next slide. So I'm sure you're all thinking, Katie, that is wonderful, but how can I locate an occupational therapist? And I'm going to tell you it can be challenging, especially as individuals with Down syndrome age. And this is because OTs who often work with adults don't have it's not that they don't have the knowledge or the skill set, because we all learned this, but just because they don't have the experience day in and day out, they often have more trouble working with our adults with Down syndrome, and they don't necessarily have the resources in their clinics because they're often set up as like rehab facilities. And then the pediatric clinics, the therapists actually have the skill and the resources, but maybe they stop seeing patients at the ages of, somewhere between 18 and 22. And also their clinics may not seem age appropriate, right? They have the smaller tables and the smaller chairs that are even too small for our loved ones with Down syndrome. So to find an OT, I recommend contacting local Down syndrome organizations. Maybe even if there's a pediatric clinic near you, see if there's someone they know in the area that sees adolescents and adults, or if you have an adult Down syndrome clinic near you, they most likely don't have an OT on site, but they would have a referral list of different therapists, perhaps that they could refer to. So all of these groups could provide recommendations. And if you're interested in pursuing occupational therapy services, you often need a referral from your primary care provider. And I recommend also checking with your insurance provider, one, to make sure that the services are provided, but two, even to see if the therapists that are recommended are, take your insurance. And then obviously for residents of Illinois, I'm available for evaluation and treatment with a referral from a healthcare provider. Next slide. So how can visual supports help adolescents and adults with Down syndrome? And this is something I do kind of day in and day out here at the Adults with Down Syndrome Center. And this is because we know and understand that individuals with Down syndrome are better visual learners than they are auditory learners for the most part. Think about, they hear a song and then they all of a sudden know the words. They watch a video and they start reciting it. So we know that just what they see, they process better. And visual supports were often used when they were younger, maybe in school or even in therapy, whether there was a visual schedule in the classroom or reward system, maybe a stop sign on the door, labels around the classroom. But what I try to tell families is that we never grow out of using visual supports, but the supports should grow and change with us. And I think oftentimes individuals with Down syndrome, as they grow up, think that these visuals are childish. But they're really just another way for us to process information. And we all use visual supports, whether it's our to-do list or our grocery list, our calendars. I want you all to look at your phones right now. There's an app photo with the word underneath, right? But we don't usually read the word. We know by what the picture of the app looks like that that's what we want. Or how many of you use emojis? Those are pictures that represent a feeling or a thought. So like I said, they're not childish. We all use them. But the purpose of visual supports, there's pictures, words, images, and they help us do many things. One, they can help us communicate. So whether it's a communication board or visuals to identify certain emotions, thinking about communication devices, so even having like touch chat on your phone, visuals help us communicate. They can also help us share or manage expectations or rules. So whether it's a daily schedule, or for individuals that don't like to shower every day, they have their shower schedule where they shower Monday, Wednesday, Friday, or they get to select the days of the week they're going to shower. Maybe it's a chore chart. Again, they share or manage expectations, establish rules. Visuals can provide reminders. So whether it's a timer, but again, a to-do list. I have my to-do list every day at work of the things that I have to get done, and then I check them off. It's just a reminder. And if I don't write it down, oftentimes I'm going to forget. Visuals can teach new skills or help maintain independence as one ages. So maybe it's the steps for bathing, or tying their shoes, or even as someone ages, instead of a memory book, we can do an orientation book or orientation photos. So putting a picture in a book of their room, and then the label on their bedroom, so they know that that's my room. This is my bathroom. These are pictures of my family members, things like that. And then finally, visual supports can facilitate understanding of challenging situations. So, during COVID, there were visuals and videos that were really helpful. If someone's dying, visual supports, a social story can be really useful, or even going for a sleep study or getting a blood draw. All of those can help, visuals can help facilitate those situations. All right, next slide. So talking about these, challenging medical appointments, how can we prepare our loved ones for blood draws and sleep studies or visits to a new doctor? And so, like I said, visuals are a great way to do this. So whether it's a social story, it could be photos of the staff that work there. It could be a video of the space. So, or even a video of, you're going to walk in, you're going to see the receptionist, you're going to hand your ID and your insurance card, and then you're going to walk and get your vitals taken. And there's a video that takes you through each step. Maybe you can even get a tour of the actual site before the visit, so that, they'll walk you through, so that they can see what they're going to have to experience, and that can, help them anticipate. Perhaps there's videos out there of people with Down syndrome talking about the procedure or the medical appointment. I know we try to put videos on our website of different topics. We are still working on some of these medical appointment ones just because it's been hard during COVID, but sometimes that can help. They see someone that looks like them doing it. Perhaps you as a caregiver can model for them. If it's the blood draw, maybe you guys go at the same time when you also need your blood draw, if that can help, just with the understanding. And then calming strategies can help. So you often might use these calming strategies in conjunction with visuals. And if you've heard me speak before, I talk a lot about sensory and using proprioceptive input as a calming strategy. So proprioceptive input is input into the muscles of joints. And so any kind of pushing or pulling activity. And again, when you think about exercise, they say exercise is great for us and we feel so great afterwards. It's because we have all these endorphins. And I'm not saying that's wrong, but I also think your body is regulated. That's how your body is supposed to feel. You've been using your muscles and joints, and your body's kind of evened out, and that's how it should feel all day. But we all teeter-totter throughout the day. So using these sensory strategies to help with things that cause anxiety, I find to be really helpful. And so in addition to sensory strategies, it could be things like deep breathing. And so we have a resource that we'll share with you about, working on calm breathing, calming our body, our muscles, and calming our thoughts, and just other ways to relax. Maybe they will tolerate a blood draw if they are, listening to music, one of their favorite songs, or maybe if they have a certain video they like to watch, and we can kind of use distraction, but those are also calming strategies for the individuals. Next slide. How do you balance independence with good health and safety? And I'm going to tell you, this is a tricky one and something we have seen a lot of lately. We also have kind of seen it as sometimes this person with Down syndrome is doing something by themselves, and therefore they're calling themselves independent. And, we view doing something without assistance and independence differently. And I know it's a hard one, and we're actually going to work on a resource to help describe this more to families. But we think asking for help can aid in independence, right? We always ask for help from someone else when we need it. And it's, I think, an important skill to teach individuals with Down syndrome, and showing them that that doesn't mean that they're not being independent. And so one way we could try to do this is maybe setting boundaries or offering choices, and that can help to develop or maintain this independence while keeping health and safety a priority. For instance, if we want to just think about healthy eating as the general idea here, someone likes to snack a lot. So maybe we set a boundary or a rule that maybe between meals, if they want to snack, fruits and vegetables are their only options, right? And maybe that will be enough for them to not snack, or at least if they're having a snack, it'll be a healthy option. Or instead of setting boundaries, you give them options. Okay, you want a snack. Do you want sliced apples or do you want carrots and hummus? Right? And again, you are presenting to them a healthy option. And again, modeling helps here. So making sure you are modeling that same behavior and you're not grabbing chips and a soda when you want a snack. But none of us makes great, healthy decisions 100% of the time. And so we have to understand that individuals with Down syndrome are going to be that same way. And so maybe having that cheat day or that cheat meal may end up helping them make better choices outside of that cheat option, right? Maybe saying, oh, you like pop, but water is the healthier option. You can have one pop a week. And so then they get to pick when that one day is. And then you can even have a visual to support that. Remember, you picked Wednesday as your pop day. And then on Thursday, when they ask for that pop, you say, oh, look at the visual. When did when did you already have it? And then they know, oh, we'll have to wait till the next week. And this isn't going to work the first time, but if you keep repeating and reiterating this information, that's how they learn best. And we want to teach them how to make these good health and safety decisions. And so, here we run a variety of social skills groups to assist with this. And honestly, because everything's been virtual, we've been able to reach, and maybe even a number of you that are on this call with some of our the skills that we teach here. Laura and I just ran a 6-week group on living a healthy lifestyle and teaching about healthy eating and drinking water and getting physical activity and getting good sleep and managing our emotions. For those that aren't able to, participate in the social skills groups, we have a ton of resources in our library. One of our favorite ones we use in many topics is Stop, Think, and Make a Good Choice, where they can create a plan. If it's hungry, when they're hungry, when I feel hungry, I will, and they can select like 3 snack foods or 3 things they can do instead. And again, we're setting them up for success by helping them create a plan. And again, with repetition and practice and good modeling, these better health and safety decisions are going to actually become a more functional groove and further the individuals with Down syndrome and their independence. Next slide. So like we mentioned, there are a variety of resources, and here are some of the links on those topics.
Thank you, Dr. Frank. Our next topic is mental health, and we are going to turn it over to Dr. Chicoine for that topic.
That was taking an answer. So first question, we get a lot of questions about grief. And first, I'm sorry that people are going through this. This certainly can be challenging. So the first question is grief different in people with Down syndrome? And how do you support a person with Down syndrome who is grieving? So the short answer is yes. Grief can be different in people with Down syndrome. We often see that it's delayed. So we often see that it doesn't, you don't really see a clear onset for 3 to 6 months or so. And some of that may be related to perhaps it's taking longer to truly understand the permanence of the loss. There may be other factors as well. And so that so this can be delayed. Sometimes we see that somebody doesn't have significant loss and they don't really seem to be grieving, but then there's sort of a relatively what you might consider a minor loss or a much less serious loss. And then somehow that cumulative effect also then tends to bring out the grief at times. Sometimes there is a component of the loss or the grief that may be associated with fear. Who will take care of me? Who's going to be my support system now that this person has passed? And so it's, somewhat self-focused. Now, I'm sure we've all probably been, had that be part of our grief at some point, but, that does seem to be an issue with people with Down syndrome at times. We do see sometimes that the grief will present with a behavioral change rather than, particularly if this person has difficulty talking about their grief or talking about, what they're feeling. And so it may be expressed in a behavioral change. Treatment can be challenging in some individuals, but a few of the things we think about. So one of the things is looking at what we call, or what a lot of people call it, in the moment. And what that would be is, there may be times where the person sort of brings it up when, you're not, it's, spontaneously, where you're not really necessarily sitting down to talk about it at that time, or planning on sitting down and talking about it. And it's often very important. We typically think it's important to kind of pause at that time if you can, and try to, give the individual at least a few minutes to try to sort through that with them a little bit, because obviously it's an important issue to them at that moment, and something we want to, kind of address with them. A big key to this whole thing is certainly listening. That's probably no surprise. Really just trying to hear what the person is what their concern is. We did give a talk on a presentation on self-talk recently, Dr. Frank and I. And one of the things some families will do, will notice that the person talks out loud to themselves in their room. And we typically recommend asking permission, but sometimes listening outside the door, you can hear what the person is concerned about, and help them perhaps based on what you learn from hearing their self-talk. And so whether it's in self-talk or whether it's something the person's able to tell you face to face, what is he or she trying to convey, and what is their sense of loss, what is their sense of need in what they're trying to tell you. Counseling certainly may be in order. Certainly someone that's experienced and has real skills in helping someone with the Down syndrome or other intellectual disability through grief may be very important. As Dr. Frank was talking about visuals and pictures, again, we find this is a good time to use those as well. We often will recommend having you can do it on your phone now. I mean, in the old days it was a little photo book, that you can have, particularly of pictures of the individual with Down syndrome and the person that has died, at some point in the past, particularly in a happy time, so those memories, can they flip that open and see, remember the happy times that brings about. Certainly reassurance that they're not alone, that someone else is going to continue to be there for them, and if their concern is in a sense of abandonment, that's not going to happen. And then in general, people with Down syndrome are many or most are very routine oriented, and so that can be very reassuring and functional for people with Down syndrome. So making sure that you try not to change the routine too much was already there, and or establish some new routines that are the person is interested in and might be helpful to that individual. You want to continue with constancy as much as possible and limit other changes if that's at all possible. You want to certainly encourage healthy eating, regular sleep, and exercise, to do everything else we can to promote mental and physical health. If the person's particularly having a challenging time, we want to make sure that there hasn't either perhaps an undiagnosed physical health issue, or something that the grief has potentially even brought on to address those physical health issues. And certainly sometimes grief keeps going, and it's really becomes more of a mental health issue with depression or anxiety that may need to be addressed as well. And certainly somebody asked, well, what medications? Really it's very individual, based on symptoms, based on the diagnosis, certainly based on the family history. What medications have the family used that were beneficial. I'd like to say that, yes, we know that people with Down syndrome have an extra chromosome, but all the genes belong to the family, so that can still play an important role. And then we certainly want to look at other health issues as well, and that also impacts on what medication we might use. Next slide. How do you treat compulsive behaviors in a person with Down syndrome with and without autism? So again, Dr. Frank and I gave a talk recently on the groove and OCD, or obsessive compulsive disorder. We encourage you to take a look at that. People with Down syndrome often have what we call the groove, this tendency towards sameness or repetition. And the webinar we gave recently had a lot of strategies for helping individuals with the groove, and also looking at when they become more problematic and really fit the definition of obsessive compulsive disorder. Again, this sounds a little repetitious, but speaking of repetitious, but a lot of the strategies include visuals, directing and also directing the person to other activities, whether it's with words or visual. We find oftentimes it's more effective to direct someone to something than to direct someone away from something. Although even that's not easy at times. And then there's a host of other strategies that we talked about in that webinar that I encourage you to take a look at. As far as autism, we know that autism includes repetitive, stereotyped behaviors. It's a part of autism, and that certainly can look like compulsive behavior. In those without autism, certainly they can develop problematic compulsive behaviors that are diagnosed as obsessive compulsive disorder. In addition to the strategies I just referred to, sometimes medications may be helpful. It's often treated with what are called the selective serotonin reuptake inhibitors, or SSRIs, or not particularly, but an example is sertraline. They can also be used in people with autism who have a tendency towards repetitious behavior, but oftentimes are not as effective for the repetitious behavior seen in autism as they are in the obsessive compulsive disorder seen in somebody with Down syndrome. So there's really not good evidence to recommend those medications in someone with compulsive behavior with autism. The other thing that there are a couple medications in the atypical antipsychotic family that are recommended or approved, I should say, by the FDA for behaviors in people with autism, or challenging behaviors or aggressive behavior. And that's a risperidone, or those are risperidone and aripiprazole. Abilify is the other name. That's pronounceable by me. And so they're FDA approved for challenging behaviors, but there is insufficient evidence to recommend those for compulsive behaviors. But we often see in folks with autism that the agitated behaviors and the compulsive behaviors are intertwined. What I call a blocking. If the person is just trying to do something repetitiously and we're trying to prevent that or direct them to something else, sometimes they will get agitated. So sometimes we do find treating with those medications in someone with Down syndrome and autism can be beneficial, and particularly around the most challenging part of the issue with regards to the compulsive behaviors is the associated agitation or aggressive behavior that can go with it. So sometimes we will manage with those medications. Next slide. What recommendations you have for treating hallucinations or vivid dreams? This is another challenging one. It can be difficult sometimes to know if the person is truly hallucinating. We do see, again, gave a presentation on self-talk, and I encourage you to take a look at that. We gave that recently, and that's on the, I guess I posted that on the question. So that we did give a webinar on self-talk, and we do see that that's a very common thing in people with Down syndrome, and also having imaginary friends is very common in people with Down syndrome. So sometimes it's hard to decide exactly where the line between self-talk and imaginary friends and hallucinations or vivid dreams, where that line is. So again, I recommend looking at that presentation on self-talk for more information. One of the things we again recommend when you're looking at this is, again, this is going to sound repetitious as well, but you want to look for underlying physical problems that may be contributing to these. And we've seen a number of folks with hallucinations that were related to, for example, sleep apnea, where they weren't sleeping well, and the disturbed sleep and the low oxygen at night ended up resulting in symptoms of psychosis. So certainly want to look at and that's not the only one, but certainly want to look at other underlying health issues when someone's having these problems. And then certainly there are a variety of medications that we will and others will use at times to treat these hallucinations or psychotic-like symptoms that can occur. And I will turn it over to the next person.
Thank you, Dr. Chicoine. Dr. Graham's going to address a question on skin and hair.
Yes, thank you. So what are some common treatments for folliculitis? Was a question that came up. So folliculitis is an infection or just an inflammation of the hair follicles, little tiny openings where hairs grow. It can be caused by bacteria that live on the skin or sometimes by fungus. Folliculitis, it looks like small red bumps or like maybe like little white pimples that appear on the skin. They can be itchy, they can be a little sore, they can be a little swollen. They can occur anywhere where there is hair on the body. Most common probably on like the face, the back, chest, sometimes legs. When infections around the hair follicles spread deeper, that's when they can become a boil. So we see a lot of folliculitis and boils in our patients with Down syndrome. So some of the ways to prevent folliculitis, we really want to try and decrease the bacteria load that lives on the skin. And so we do that with using a really gentle cleanser. You know, antibacterial soaps, HibaCleanse is one that's over the counter that we use frequently. Also, you can look at using like benzoyl peroxide soaps. A lot of like acne medication or acne face washes have benzoyl peroxide in them. You just have to be a little careful because benzoyl peroxide can leave stains on towels and on fabrics, so beware. We do recommend that when using these gentle cleansers to use like a loofah sponge or something that you can scrub with. We don't want it to be too rough because like vigorous scrubbing can actually make some of the symptoms of folliculitis worse, but just like some gentle scrubbing. So a gentle loofah sponge, sometimes on a brush or like a long brush can be helpful so people can reach a little bit better. It's also really important that after we rinse the skin and we dry off, that we totally dry off. We find that if people do a quick dry and are still a little bit damp when they get dressed, that can also make some of these skin conditions worse. So making sure that we are really dry, sometimes even using like a blow dryer to make sure that we're really dry before getting dressed can be helpful. The other thing that sometimes dermatologists recommend is you can take like a bleach bath. So that's when you use a 1/4 cup of bleach in a bathtub full of water for 5 minutes. Make sure it doesn't go on the face, the eyes, hair, but sometimes that can be helpful for the skin and for decreasing the bacterial load. It can irritate people who have really sensitive skin. So you kind of have to, start with a really, really low amount of bleach and just see how people respond to it. In general, a good moisturizer lotion is recommended. Something I always tell people, pick something that's unscented, because any of those like lotions or creams that have like a smell can actually be a little bit irritating for sensitive skin. So looking for something that's unscented, really like for sensitive skin is typically best. We also find that sometimes applying like a powder can be helpful, especially if you see that the folliculitis or even boils are happening in high friction areas. And so that would be like armpits or groins, on waistlines or on bra lines. If you can use like a baby powder. Recently, I've been kind of introduced to a calamine lotion that's in powder form. This is all over the counter stuff. Sometimes they make like friction powders for athletes or for cyclists and things like that. And so using a powder like that in some of those high friction areas, it can be really helpful. If you have really severe symptoms of folliculitis that's not really responding to any of these treatments, sometimes it's appropriate to do a short course of antibiotics for a couple of weeks, oral antibiotics, to try and decrease the bacterial load. So that's kind of the general approach that I would take to folliculitis. Next slide, please. So these are the links to some of the articles that are available, not just for folliculitis, but boils, hidradenitis suppurativa, some of the other common skin conditions that we see. So back to you, Laura.
Thank you so much. Now Dr. Chicoine is going to address some questions on aging. And we are going to take questions until 4:15. And if you have to drop off, again, we'll send that the recording out to you.
Okay. So what health issues are common as individuals with Down syndrome age? So we've talked a little bit about some of them with Dr. Graham mentioned Alzheimer's disease. And that's certainly one that is very front and center for most people. So when they're considering Down syndrome and aging, there's unfortunately people with Down syndrome often have several co-occurring conditions, and some of these can increase in frequency as people age. And we do know that early aging in Down syndrome is a real thing, and so some conditions can occur earlier in people with Down syndrome than they might in someone else. We also do know that, interestingly, that some conditions occur more frequently, as I mentioned, Alzheimer's disease and cataracts is another one. And some actually occur less frequently. Solid tumors, colon cancer, breast cancer, and also atherosclerosis, the hardening of the arteries, if you will, the buildup of plaque in our arteries that causes heart attacks is actually less common in people with Down syndrome. Some conditions can occur throughout the life of people with Down syndrome, and so if they didn't get it when they were younger, they might develop it later. So like thyroid disease is more common in general and can occur at any age. Someone asked about kidney disease. It's interesting. Not a lot is known about kidney problems in people with Down syndrome, but we do know that people with Down syndrome, from some small studies, suggest that people with Down syndrome may have a fewer number of kidney cells than someone else. So we do commonly frequently see people with Down syndrome have some mild decrease in their kidney function, and certainly not drinking enough fluids, which I think a lot of people with Down syndrome, a lot of us in general, but a lot of people with Down syndrome, I think that's the case. They don't drink enough. So certainly if their kidney function's a little on the border and they're not drinking enough, they're more likely to have further worsening of their kidney function. So in general, I would encourage you to take a look at the global adult healthcare guidelines that were published in 2020, and you can find the link to that on our website. And it goes through a number of health conditions that and what we might think about the screening for them as people with Down syndrome get older. And there will be another version of that. I talked about the colon and breast cancer. There will be an additional version of that as we go forward, coming up in the next few years, several years perhaps. And so some additional questions will be answered as well in the guidelines. So take a look at what we have so far, and I encourage you to keep tuned in for more information as we go forward. Next slide. What are ways to help a loved one with Down syndrome get optimal care for health providers as they age? There's a number of questions about trying to get individuals with Down syndrome appropriate health care. So one of the things that I would, as a starting place, is really try to find what's called a medical home. And that's a primary care provider. And that provider can organize healthcare, monitor the care of multiple providers. And this is really important. Again, this is a population of people that unfortunately does often have a variety of co-occurring conditions. They might have thyroid, diabetes, or celiac, or skin problems, vision problems, hearing problems. So there's unfortunately some of the folks with Down syndrome have a number of health issues, and so they might see a number of specialists. And so having a primary care physician, having a medical home, well, really that can kind of be organized, and you can make sure that what Dr. X is recommending for this condition is not actually aggravating either the medication that Dr. Y is providing or prescribing, or the condition that Dr. Y is treating. So important to have a primary care provider to kind of overlook that. Also, they can monitor, the person can monitor medications. And so we would encourage you to, when you find a good primary care provider, stay in touch with them. So if you see a specialist, make sure that the primary care provider knows that the medication has been changed, and there's a new diagnosis or whatever, so that he or she can kind of keep on top of things. How do you find that person? The first thing I recommend is talk to other families. Find a provider in your area that other families have found is serving well as their medical home. You might also look at the Down Syndrome Medical Interest Group webpage or Global's website for other healthcare providers across the country. And again, that information is available on our website. If review and bring the healthcare guidelines I just talked about a moment ago. Bring those with you. Share them with your provider. It's a recent study estimated that about 5% of people with Down syndrome have access to a Down syndrome clinic, and obviously 95% do not. So, trying to bring some information to your provider may be a helpful way to optimize care. Look at our online resource library, and then we have lots of questions there, and or lots of materials there to help you answer your questions. And if you don't find it, we have a spot where you can actually send in a question, and then we can develop additional educational materials. The other thing I would, if you have things you feel like you'd like your provider to know more about, encourage your provider to take a look at the Down Syndrome Medical Interest Group. And again, that information would be on our webpage, but DSMIG or DSMIG, if you just Google it, you can find it. There's one in the UK, and there's one in the USA. So obviously, depending on where you live, which one you're looking for. But and so there's lots of information on that site, and certainly there's even more information available to a health professional that joins DSMIG, and it's a very reasonable annual membership fee, and that we encourage you, to encourage your provider to take a look at that. And then someone asked about wholehearted care, and I think what the person was referring to is what I would call holistic or patient-centered care. Really, it's a successful approach for our practice, and certainly it's been shown in studies to be a successful way to address individuals or patients. It really includes listening, giving the person an opportunity to participate. Certainly, our appointments take longer because we really try to give the person with Down syndrome an opportunity to participate in the appointments. Really looking at the whole person. It's so important for all of us, but really particularly for people with Down syndrome, and I think communication has something to do with it, probably, or the challenges of communication. So we see so much interaction between the mental, physical, and social health of individuals we see, and so really trying to sort through all of those areas of their life is so important to try to optimize their health care. And then certainly look at what is families are so important to individuals with Down syndrome for support and other aspects. So how is the family? What's the impact of the family on the individual's health conditions, and how can we support the family as well? And then what are the goals? What are the family and the individual with Down syndrome? Where were they trying to go, and how can we help them get there with regards to their health needs? Next slide. How do you know an adult with Down syndrome needs hospice as he or she ages? So, this is a very individual decision and choice. So, it's hard to answer this broadly. But first off, I would say, when we're looking at that, we're looking at, looking at the goals of care and looking at, what is it that we're, is there a condition that's not treatable, and we're looking at potentially not continuing treatment in the sense of looking at longevity, but we're looking at treatment more from a comfort level. So in Illinois, for example, if you are making a decision for somebody else with regards to these advanced directives or the decisions with regards to doing CPR or intubation and those kinds of things, if you're making the decision for somebody else, which often happens in our practice where the family will be making the decision for the person with Down syndrome or with the person with Down syndrome, in Illinois, really one of three conditions have to be there, and that's a terminal illness, an incurable illness, or a permanent vegetative state. So Down syndrome is not one of those three things. And so deciding hospice purely on the basis of Down syndrome, I'm not a lawyer, but in my opinion, is not something that I would think is within the confines of the law in Illinois. So it really is based typically on co-occurring conditions. And oftentimes we're having this discussion when it comes to end of life discussion with regards to Alzheimer's disease would be the most common time that this comes up. And so really you want to look at, the goals of care. What are we looking, at this point with all the health conditions that the individual has, are we looking to prolong life, or are we looking primarily at comfort for the days that the person has left, if you will? So my approach is that, I don't look at hospice as not having something to offer somebody. I look at it as we always have something to offer the person with regards to medical care. But again, it's just what is the goal and what is the direction that the care is going in. So are we looking to prolong life, or really looking to shift to comfort? And that really is when we would really be talking about hospice. So, if you have a question with regards to this, certainly talking to your primary care physician or perhaps a specialist that's involved in his or her care. But also you might look at talking to a palliative care specialist or a hospice, if you talk to a hospice organization, doesn't mean you are committed to those services. They are usually typically very happy to talk to you and just to share what it is they have to provide and try to see if that fits your goals and needs. And then certainly if you have further questions, most hospitals or many hospitals will have an ethicist that can help with those decisions. And we have quite a bit of information on aging. The National Down Syndrome Society has a very nice guidebook on aging. In fact, they're having an upcoming version. I helped review it for the author, so it's very nicely done. So there's lots of good information out there, and I encourage you to take a look at that on our website.
Thank you. Our next topic is orthopedics, and Dr. Graham is going to provide information on that.
Okay, thank you. So the question that I have here is, what is atlantoaxial instability? How do we screen for it, and how is it treated? So atlantoaxial instability is commonly abbreviated as AAI. It's defined as excessive mobility of the C1 and C2 vertebrae, which are called, C1 is called the atlas vertebrae and C2 is called the axis. So this can lead to subluxation of the spinal cord. So basically what I describe this as is it's like a dislocation of the top two vertebrae in the spine. And when those two become dislocated, it can push on the spinal cord and harm the nerves, which are moving through the center of the spinal cord. So that can be a bad thing. The reason that this seems to be more common in people with Down syndrome is because of the excess flexibility of the ligaments in the spine. So the Global Down Syndrome Foundation 2020 guidelines did offer some information about how to screen for this in our patients. As a side note, those guidelines are an excellent resource for the care of people with Down syndrome. So I would encourage you to take a look at it sometime, share it with your healthcare providers. It's, I think, just a really helpful resource, really for addressing some really common things. But they do talk about atlantoaxial instability. They say that, quote, routine cervical spine x-rays in adults with Down syndrome should not be used to screen for risk of spinal cord injury in patient asymptomatic individuals. So that's people with no symptoms. Instead, annual screening of adults with Down syndrome should include a review of signs and symptoms of cervical myelopathy, which is that pushing of the spinal cord, using a targeted history and physical exam. So in like normal talk, we would say that we don't need to do x-rays on a regular basis to screen for atlantoaxial instability. What we're going to do is monitor symptoms and monitor the physical exam. So the physical exam is something that your healthcare provider would be able to do. And that usually includes a reflex test where we're testing all a variety of different reflexes in the body. You know, the classic one of the knee jumping out, but then there's also several in the arms that we test as well. So that's the physical exam portion. The other part is the symptoms portion. We're just screening for any symptoms of atlantoaxial instability, which can be a little bit hard to pin down at times, but some things that maybe you should be on the lookout for would be changes in how we're walking, problems with balance, losing motor skills, so not being able to move or do a skill that we used to be able to do. Also, loss of bowel or bladder control can be another sign or symptom. Neck pain, while sometimes difficult to pinpoint the cause of neck pain, anybody with Down syndrome who's having neck pain, we should probably think about atlantoaxial instability and also neck stiffness. So if anyone's having those symptoms, or if anyone is having an abnormal reflex exam, then we usually reflex to, or we go to do the imaging. And that's kind of an update from some of the previous guidelines, but I think that the 2020 guidelines are really clear, really helpful resource. So hope that helps answer the question. Next slide, Laura. And this is a link to that guideline and some other links for you to review. So back to you, Laura.
Thank you, Dr. Graham. I'm going to invite our panelists to start their video. We are out of time, but we want to thank everyone for joining us today and for submitting your questions. I know we didn't get to all of them. We encourage you to check out our resource library. There is a search bar there. And so if you, you might be able to find some answers to your questions using that. And if not, there is a contact form that you can submit and we can try and identify a resource for you. So we hope you have a wonderful rest of your afternoon.
Thanks for coming.